Welcome to CE Conversations, a clinical podcast presented by Creative Educational Concepts, designed to improve clinician performance and optimize patient outcomes. This session, entitled Interprofessional Perspectives on the Evolving Heart Failure Treatment Paradigm, harnessing novel therapeutics to optimize outcomes and overcome disparities in care. This accredited activity is available for 1 hour of ACCME, ANCC, and ACPE credit. It is supported through an independent educational grant from Merck. To earn CE credit and complete the evaluation for this activity, please visit the link in our show notes after the podcast. And with that, we will turn it over to our expert faculty.
Thank you so much for the warm introduction and to all of you for joining us. My name is Muthu Vadagnathan. I'm a cardiologist at Brigham and Women's Hospital in Boston, Massachusetts, and Harvard Medical School. And this program is presented by Creative Educational Concepts and supported through an independent educational grant from Merck. I'm the co-director of the Center for Cardiometabolic Implementation Science at Brigham and Women's and Harvard Medical School. These are my disclosures. We'll start out with a few learning objectives. We'll take a deep dive into the clinical gravity of heart failure and pay particular attention to updates related to nomenclature and distinctions of various categories of heart failure. We'll appraise the impact of social determinants of health on heart failure outcomes, and we'll summarize recent clinical practice guidelines as well as expert consensus decision pathways in heart failure, and interpolate novel therapeutics in the heart failure decision pathway and how these treatments juxtapose with traditional therapies we're used to administering. And finally, we'll end with a case-based format with a real-world case to understand how we can design evidence-based supported treatment plans for heart failure with reduced ejection fraction based on guideline-directed medical therapies, including novel therapeutics on the background of a highly variable and heterogeneous population to promote equitable health outcomes at large. So the universal definition of heart failure was recently released that specifically introduced a common definition of how we can understand heart failure. The universal definition puts forth that patients must require signs and symptoms of heart failure caused by structural or functional cardiac abnormalities that are corroborated by one of the following: an elevated natriuretic peptide level or objective evidence of cardiogenic pulmonary or systemic congestion. That's either on physical examination or on radiography. The universal definition of heart failure then reframes the traditional staging, stage A, B, C, and D, to those who are at risk, to those who are pre-heart failure, and then a large category of patients who have stage C heart failure or overt heart failure. And these are the patients we commonly encounter in clinical practice and treat. A minority of these patients progress to advanced heart failure, those who are requiring either mechanical circulatory support or transplantation options. Within the chronic heart failure stage C category, there is a subset of patients that enter in a worsening heart failure cycle. Up to 1 in 6 individuals after initial diagnosis of heart failure with reduced ejection fraction may experience a worsening heart failure event. That is, worsening signs and symptoms of heart failure, either in ambulatory care or requiring hospitalization for heart failure, despite optimal medical therapy. And unfortunately, this cohort of patients who progress to worsening heart failure are particularly high risk and face a 2-year mortality of over 20%. In the United States, over 6 million Americans have heart failure, with about 1 million diagnosed each year. About another 1 million patients are hospitalized for a primary indication for heart failure. And of course, the totality of this burden contributes to excess health system costs, upwards of greater than $30 billion. Today, heart failure has undergone a series of changes in terms of nomenclature and how we actually categorize and think of and conceptualize heart failure. The universal definition of heart failure, and indeed now clinical practice guidelines, embrace now a common definition based on ejection fraction. Ejection fraction, while defined based on a single time point measurement and the subject based on inter-individual variation as well as inter-reader variation, is a tool that we can use to best differentiate patients that may not only phenotypically behave similarly, but also therapeutically may respond to investigational and traditional therapeutics similarly. Based on this ejection fraction classification, we divide patients as heart failure with reduced ejection fraction, that's less than or equal to 40%, heart failure with mildly reduced ejection fraction, that's EF between 41 and 49%, heart failure with preserved ejection fraction, that's greater than or equal to 50%. And then there's a subset of patients, of course, that initially started low in this reduced EF category, but subsequently improved their ejection fraction, either over time with time and distance from the incident event, either acute MI or another systemic event, or medical therapy. And if they recover above 40% with at least a 10% delta, those patients are known as heart failure with improved ejection fraction. We're not going to have time to deep dive into the pathophysiology of heart failure. However, we know that there are clusters of variables and clinical characteristics that define these extremes, at least heart failure with reduced and preserved ejection fraction. Even today, the most common pathway to heart failure with reduced ejection fraction is a myocardial infarction and ischemic cardiomyopathy, such that clinical characteristics that relate to this ischemic pathway, such as men, smoking, atherosclerotic cardiovascular risk factors, older age, all coexist with heart failure with reduced ejection fraction. In contrast, preserved ejection fraction is quite a bit more variable. Atrial fibrillation, chronic kidney disease, obesity, systemic factors commonly coexist. And in fact, there's a unique demographic footprint such that women are predominantly affected and people of older ages are commonly affected. Unfortunately, despite best available evidence and therapeutics, heart failure mortality in the United States has stagnated. And in fact, in certain racial and ethnic populations, it's actually increased over time. Indeed, in this examination, Black men and Black women had higher rates of mortality in recent years, especially in the younger demographics. Unfortunately, COVID-19 hasn't helped progress in the heart failure space, in which COVID-19, although has introduced alternative ways in which we can access patients, such as telemedicine, it's also introduced and highlighted inequities in care. This piece in Circulation stated that on the unsteady foundation of a pre-existing digital divide, a new tower of inequity in access to care will be built. These investigators and authors are discussing the role of telemedicine plays on the background of existing inequities in care. And in fact, there are many social determinants that may become problematic when we think about virtual care and in heart failure outcomes. For instance, there may be challenges in maintaining care quality over time using telemedicine options. There may be privacy concerns for many individuals. There may be a lack of cultural acceptance. Certainly, many individuals may not have primary access to video capabilities or translation services and may be concerned about home qualities or backgrounds. In fact, these investigators said that COVID-19 pandemic has been the great unequalizer. And in fact, we've seen that telemedicine compared with more traditional telephone visits in this virtual environment is more commonly or less commonly seen in women, non-English speaking individuals, older patients, and patients of poorer socioeconomic backgrounds. Furthermore, there may be disparate access to inpatient care. This is in my very own health system at Brigham and Women's Hospital, in which a retrospective examination of 2,000 patients hospitalized for heart failure via the emergency department showed that the triage patterns were actually variable based on race and ethnicity. Importantly, patients of Black or Latinx backgrounds were less likely to be triaged to specialty cardiovascular services independently of other clinical comorbidities and clinical risk status. Furthermore, we've seen variable access to novel therapeutics as they're introduced into clinical practice based on race and ethnicity and socioeconomic factors. This retrospective cohort study found that SGLT2 inhibitors, the latest pillar of care in heart failure with reduced ejection fraction, was disproportionately lower in those at highest risk. Those are patients with heart failure, chronic kidney disease, or atherosclerotic cardiovascular disease. Indeed, similar inequities were seen with respect to Black patients, women, patients of lower socioeconomic status. So unfortunately, we're seeing this risk treatment paradox such that our highest risk patients in clinical practice are least likely to obtain and receive and remain on high quality evidence-based therapeutics. And we see this play out over time, in which patients overall on the left-hand panel who are most likely to receive these therapies, for instance, in this case, the SGLT2 inhibitors, are less likely to be the ones where the evidence is strongly there, for instance, heart failure with reduced ejection fraction. Furthermore, in the right-hand panel, even over time, we see persistent gaps based on race and ethnicity, in which, in orange, Black individuals are less likely to receive these therapies. Cost and access remain a very high priority in terms of potential issues that may widen current inequities in care. We know that the costs of heart failure care has grown with growing evidence base for newer therapeutics in clinical practice. And furthermore, patients in practice may have to make challenging trade-offs such that paying for their bills, either in the hospital or prescription bills, may have to trade off with utilities or food. And certainly contending with this complex intersection is one that we'd like to help patients with. Importantly, though, even for established therapeutics, such as generic therapies in heart failure care, we do see inequities in care in which some patients still are not receiving optimal guideline-directed therapies. And so while cost and access are an important issue, it's not the entire problem that we face in clinical care. So taking this entirety of evidence together, these investigators put forth the notion of pharmacoequity that ties together each of these individual pieces that contribute to variable access and prescription of therapeutics across various dimensions of socioeconomic status, particularly race, ethnicity, and socioeconomics. So where are we with heart failure care today? The 2022 ACC-AHA-HFSA and the 2021 ESC heart failure guidelines were very recently released, and both commonly provided high-level guidance as class 1 indications for combination medical therapies with 4 drugs. That is an angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, an evidence-based beta blocker such as carvedilol or metoprolol succinate, and evidence-based mineralocorticoid receptor antagonists such as spironolactone or eplerenone, and an evidence-based SGLT2 inhibitor such as dapagliflozin or empagliflozin. All these therapies used in combination are class 1 recommendations and first line. The rationale for the combination use of these therapies is that many of these therapies actually target non-overlapping therapeutic pathways. For instance, the beta blockers target the sympathetic nervous system. The renin-angiotensin system inhibitors target angiotensin II production. ARNI targets the neprilysin axis. The mineralocorticoid receptor antagonists target the steroidal, the nuclear receptor, the MR receptor, and the SGLT2 inhibitors target the SGLT2 transporter predominantly in the kidneys. So if theoretically the use of these therapies provide benefits that are additive, when used over a lifetime, since heart failure is indeed a chronic condition, these therapies may afford substantial extension in survival and survival free from clinical events such as heart failure hospitalization. For instance, in this simulation analysis of a 55-year-old patient with heart failure with reduced ejection fraction, we estimated that combination medical therapy with these 4 drugs compared with more conventional therapies, such as a renin-angiotensin system inhibitor and a beta blocker, may afford up to 6 additional life years gained, free of overall survival. Unfortunately, in clinical practice, we know that using all therapies in all patients may not be technically feasible. And this may be limited not just by cost and access, but also by physiological parameters such as heart rate, blood pressure, kidney function, and electrolytes. Beta blockers may be limited due to low heart rates. The renin-angiotensin system inhibitor, or more notably valsartan, may be limited due to low blood pressure. The MR antagonist may be limited due to advanced kidney disease or hyperkalemia. So how do we actually operate when there's so-called limited spending function, when there's actually true physiological limitations in use? Thankfully, we've seen expansion in therapeutic options in heart failure with reduced ejection fraction, in which we have new options that may actually provide benefits to patients, even in these challenging high-risk scenarios. The first I'd like to discuss is ivabradine. Ivabradine is a funny channel inhibitor. This is reaching back to medical school days, but funny channel is uniquely expressed in the sinus node of the myocardium, such that inhibition of the funny channel allows for selective slowing of the sinus rate and allows for lower heart rates. Ivabradine was tested in a landmark trial called SHIFT. This was a trial of patients who were optimally treated with maximally tolerated beta blockers, and despite that, had elevated heart rates and sinus rhythm above 70 beats per minute, and were randomized to ivabradine or placebo. And in fact, this investigational therapy proved to be successful in reducing the composite of cardiovascular death or worsening heart failure events. Importantly, this therapy is relatively hemodynamically neutral. It has limited effects on blood pressure. However, it's only effective in those individuals who are in sinus rhythm. So cannot be used in patients, for instance, with atrial fibrillation with rapid ventricular response, despite beta blockers. Can't be used in patients with paced heart rhythms, but certainly may have a role in those who are already on maximally tolerated beta blockers that still have elevated heart rates in sinus rhythm. Next, I'd like to discuss the soluble guanylate cyclase stimulator, vericiguat. So vericiguat targets a very unique mechanistic pathway of CGMP. So vericiguat acts intracellularly and increases cyclic guanylate cyclase activity such that CGMP production is increased. CGMP is a central actor that provides favorable effects both in the myocardium as well as the vasculature. In the vasculature, to allow increased CGMP production allows for decreased vascular stiffness and arterial constriction, providing vasodilation. In the myocardium, it decreases myocardial stiffening, thickening, and it promotes remodeling as well as reduced fibrosis. The phase 3 Victoria trial was specifically designed to evaluate vericiguat after a hospitalization or ambulatory care visit for worsening heart failure. So this trial specifically enrolled symptomatic high-risk patients with chronic heart failure with an EF less than 45% and a recent worsening heart failure event. This table just juxtaposes Victoria, you see in the third column here, compared with other landmark clinical trials that have paved the way in terms of quadruple therapy. I'll note two important distinctions. This is a very, very high risk cohort of patients after a recent worsening heart failure event. This is in contrast with relatively stable patients seen in the other landmark clinical trials. Furthermore, Victoria tested a population with broad EGFR inclusion criteria such that vericiguat was tested in up to patients down to an EGFR above just 15, so anyone essentially not on dialysis. In this very high risk group of patients, vericiguat on the background of best available care reduced clinical events, that was the composite of cardiovascular death or heart failure hospitalization, by about 10%. So about a modest relative risk reduction. However, because the clinical risk in this population was so high, the absolute risk reduction was actually quite substantial, an absolute risk reduction of about 4, translating to a number needed to treat about 24 per year. So this led ultimately to FDA supporting use of vericiguat for reduction of cardiovascular death or heart failure hospitalization, specifically following a worsening heart failure event, and now has been introduced in both clinical practice guidelines in the US and Europe as a class 2B recommendation. So that is, could consider in select scenarios in this high-risk patient population who have experienced worsening heart failure events despite best available therapies. Importantly, vericiguat is being studied in a sister trial called Victor. This is with an adjacent population of patients who have not had recent worsening heart failure. This is testing vericiguat against placebo in 6,000 individuals with an EF less than 40% who have not had a recent worsening heart failure event and is anticipated to complete in 2025. Next, we'll move to IV iron. IV iron has been tested in several randomized clinical trials, most recently in the HFrEF trial. This was a landmark study that tested one formulation of IV iron called ferric carboxymaltose. IV iron was specifically designed to circumvent one of the problems with oral iron absorption in chronic heart failure. Importantly, patients with heart failure express high levels of hepcidin, which preclude the initial absorption and uptake of iron, as well as the subsequent metabolism of iron in the body and utilization of iron in the body. IV iron has much higher bioavailability and allows for more optimal uptake. So HFrEF tested the strategy of repletion in the hospital of iron stores, even in the context of functional iron deficiency, and compared it against a placebo. And in fact, over the course of just a year of follow-up after hospitalization for heart failure, ferric carboxymaltose led to a substantial 21% reduction in the primary composite outcome of total events. However, this was of borderline statistical significance. And in fact, this was one of the first trials that was impacted by the COVID-19 pandemic. And when censoring the events that were influenced by COVID-19, we see that there's a more substantial, statistically significant 25% risk reduction in clinical events. IV iron is now being tested in a larger trial called HFrEF. This is over 3,000 patients with stable heart failure with reduced ejection fraction, again with an inclusion criteria that encompasses functional iron deficiency. That's essentially serum ferritin that's frankly reduced, less than 100, or in this functional iron deficiency range, between 100 and 300, with a reduced TSAT, transferrin saturation, less than 20%. Furthermore, Ironman is being conducted and also should report very soon. This is another trial testing a different IV iron formulation, iron isomaltoside. This is patients who are high risk with either a recent worsening hospitalization for heart failure or elevated natriuretic peptide levels, and is again an outcome-driven trial evaluating cardiovascular death or heart hospitalization for worsening heart failure. So clearly, our armamentarium of heart failure has rapidly grown in recent years, and a one-size-fits-all approach may not be the case for many individuals, either due to either direct physiological impairments, such as limitations in heart rate, blood pressure, kidney function, or electrolytes, but also cost, access, and appropriateness. The ESC put forth this nice decision pathway of phenotypic profiling in which they actually segmented patients based on those hemodynamics, electrolytes, kidney function data, and allowed for a more practical approach such that each individual profile can then be, we can look into and see which therapies your patient may actually be eligible for. The other issue at hand is where we draw the line to define heart failure with reduced ejection fraction. I started off by discussing that the universal definition of heart failure and our contemporary clinical practice guidelines define HFrEF as an EF less than or equal to 40%. However, we know that patients, even at higher ejection fraction, let's say 50, 55, 60%, in covering this mildly reduced group of patients, actually do behave therapeutically similar to patients with heart failure with reduced ejection fraction. Said another way, many of the elements of quadruple therapy actually may benefit a broader group of patients beyond just a core set of heart failure with reduced ejection fraction. So in upcoming clinical practice guidelines and expert consensus pathways, we may see a shifting dialogue about consideration of these therapies even at higher ejection fractions. We know kidney function is a critical determinant of allocation of these therapies in clinical practice, such that patients with more advanced kidney disease are less likely to be treated with guideline-directed medical therapy approaches. This is a snapshot from Get With the Guidelines Heart Failure Registry, which is the largest inpatient registry in the United States that's ongoing. And you can see across every therapeutic class, as you march to the right towards the orange, which is dialysis, you see that the use of these therapies is less frequent, such that patients on combination medical therapy are very infrequent when you reach eGFR ranges of even 45, and especially when you reach an eGFR range of 30. Even implementation outside of these high-risk groups of patients, though, has been slow. For instance, in the most recent pillar of care, the SGLT2 inhibitors, we see that despite the rapid accumulation of high-quality evidence, less than 10% in most registry and administrative care data sets are using an SGLT2 inhibitor in clinical practice. It is said that it takes about 17 years for an investigational therapy that initially receives regulatory approval to reach so-called ideal uptake. However, in practice, how can we work together as a system to actually improve this uptake and close this implementation gap such that we're not waiting 17 years to implement guideline-directed medical therapies that are now endorsed in the 2021 and 2022 clinical practice guidelines? So we'll move to a case to best gel this together and bring together these various components. SK is a 65-year-old woman with heart failure with reduced ejection fraction with an EF of 35%. She's been lost to follow-up after a decompensation for heart failure 2 years ago, and now she's readmitted. This is probably a common thread and a common patient you may have encountered in your own clinical practice. Currently, she's taking losartan, 50 milligrams once daily, spironolactone, 25 milligrams once daily, carvedilol, 6.25 milligrams twice daily. Her systolic blood pressure is 130, her eGFR is 45, and her serum potassium level is 4.8. Upon admission, she was initiated on IV diuretics. She has resolved symptoms. She feels better. She's approaching discharge. Often, and most often, especially in the United States, patients are discharged without other changes in therapeutics, including the heart failure therapeutics, after initial stabilization. However, what are some of the appropriate guideline-directed considerations to improve her heart failure with reduced EF treatment during hospitalization? We're meeting these patients at a very critical junction after stabilization of this high-risk juncture and entering, hopefully, a plateau phase of stabilization. Unfortunately, even after that first incident heart failure event, mortality risks in the subsequent 2 years substantially increases. And in fact, patients who have recurrent heart failure hospitalizations face a tremendously high risk of near-term mortality. Heart failure hospitalization represents a critical moment for guideline-directed medical therapy optimization. In fact, in a prior registry-based analysis of about 2,000 individuals who were eligible for an MR antagonist, only about a quarter were actually discharged on the MR antagonist. In those who were discharged on the therapy, 80% actually failed the therapy in 90 days. In those who weren't discharged on therapy, very few actually subsequently were started on therapy. So although we may write in our discharge summaries, communicate even to our post-discharge clinicians that these therapies should be started in the early post-discharge setting, they often aren't, and empirically, it is now been shown and even proven that if we don't start these therapies at the time of a worsening heart failure event, they often may never be started in ambulatory care. This document takes us through the various technicalities of initiating, switching, and stopping harmful therapeutics during a hospitalization for heart failure. And in fact, states that this actually provides a fairly equitable opportunity. Unlike ambulatory care, where we meet a relatively selected group of patients that have the access, transportation to actually present to an ambulatory care visit. Hospitalization, you meet patients of various payer demographics, various races, ethnicities, age bands, and this actually provides an equitable opportunity to provide guideline-directed medical therapy optimization to a broad group of patients. The 2021 ACC Expert Consensus Decision Pathway provides some critical advice to common scenarios that we encounter in practice that may prohibit us or slow us in optimizing therapies. It takes us through individual eligibility criteria for each of the guideline-directed medical therapies. Furthermore, discusses particular pain points, issues that we all face about patient non-adherence, especially that socially high-risk patient who faces non-adherence. That is upwards of 20 to 50% of the patients we see in clinical practice. And unfortunately, we know that non-adherence, while we often blame the patient, actually has quite multi-layered and may have inputs on part of the clinician. There may be poor education, poor communication, the health system, there may be siloed care or transitions in care. And so this actually provides a critical opportunity to assess those gaps, to allow for a prospective plan to close them and address them to best optimize not only initial care, but also longitudinal care of our heart failure patients. So some of the aspects are listed here that the 2021 ACC Expert Consensus Decision Pathway puts forth, but I'll highlight in italics here the interprofessional nature of the recommendation that Interprofessional communication and the collaborative care approach may best fill gaps in care and may best bridge the high-risk transition from hospitalization to home or to a nursing facility. In terms of that follow-up care, the ACC Expert Consensus Pathway also puts forth this acronym, I need help. So I Need Help was designed to identify patients who may benefit from an advanced heart failure specialist referral, but really does identify our highest risk patients who are on the trajectory to worsening heart failure. So I stands for IV inotropes. N is advanced NYHA class. E is end organ dysfunction, worsening kidney function, liver function. E is significant impairment in ejection fraction. D is defibrillator shocks or ventricular tachyarrhythmias. H is additional or excess hospitalization burden. E is edema despite diuretics, that's congestion despite best diuretic management. L is, of course, low blood pressure, high heart rate, adverse hemodynamics. P is prognostic medication de-escalation. So this is really when you see yourself down titrating the ACE inhibitor dose, that's a sign that we need to actually move towards advanced therapy planning. Furthermore, we know that there's been a tremendous expansion in mobile health tools and devices to aid in management of heart failure. This is one such app called Treat Heart Failure that the ACC put forth. This is a really handy app that can be accessed on your mobile device in the clinic to aid in specific and really personalized decision-making based on some very simple inputs about what your patient may be eligible for and some of the gaps in their care plan. So to summarize, there are substantial and pervasive disparities across the continuum of heart failure care, and quadruple therapy, ARNI, beta blocker, MR antagonist, and an SGLT2 inhibitor represents the new standard of care and guidelines supported both in the United States and in Europe as first-line medical therapy for heart failure with reduced ejection fraction. There are several novel therapeutics that fill important role, especially when we face issues related to physiological limitations of using core guideline-directed medical therapies. Hospitalization for worsening heart failure is an absolute critical juncture in which we meet patients and may be well positioned to initiate and optimize heart failure medical therapies. The application of standardized tools and quality improvement, especially in this hospitalization window, may best allow us for the equitable implementation of comprehensive medical therapy in clinical practice. I really thank you very much for your time.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and most importantly for the patients you serve. Please proceed to the link in the show notes to complete the activity evaluation and claim your CE credit. Thank you.